Welcome to Health Talk. Thank you for joining us today. Today we have with us Dr. Augusto Bastidas. He is a gastrointestinal surgeon. He is with us today. We're going to talk about gastroesophageal reflux or heartburn. He's practicing at Los Gatos Community Hospital, Good Samaritan Hospital, and also El Camino Hospital. Welcome.
Thank you, Gloria.
So what is reflux and how is that different from gastroesophageal reflux problems?
Well, I wanted to discuss this topic today because heartburn is so common and gastroesophageal reflux is very common. And what I'd like to do first is go over the anatomy so we all understand what we're talking about. I have a drawing here that shows the esophagus, which is the swallowing tube that comes down through the back of the chest and crosses over where the diaphragm is, enters the abdomen, and then we have the stomach here, and then the stomach empties into the intestine. And reflux is basically the movement of gastric contents from the stomach up into the esophagus. And the reason that people get heartburn or symptoms from the reflux is that there's usually acid in the stomach, and the acid is very irritating to the esophageal lining.
Now, in reflux, which is very common, and that people can have it for many years, and they just take Pepto-Bismol forever, and this is the $7 or $8 billion industry. So tell us how they get to your office.
Well, as I mentioned, gastroesophageal reflux is very common. In fact, reflux, or the movement of fluid from the stomach to the esophagus, is a normal phenomenon. Everybody has reflux. It only becomes a problem when it becomes very frequent or very severe. And so in patients who have more severe disease, they tend to present with chest pain or epigastric discomfort. Those are the most common symptoms, and that's what most people think of as heartburn. Now, what's unfortunate is that you can actually be walking around with fairly significant reflux disease without typical symptoms. Some patients get atypical chest pain, which can be confused for heart disease. Other patients have more subtle symptoms like a chronic cough or even exacerbations of asthma. And later on, when there's damage to the esophagus, you can also have problems actually swallowing.
So when a patient comes to you, presumably they've had reflux for a while, or it's so severe they seek attention of a surgeon. Now, when they come to your office, what will you ask them, and what will they expect to have done?
So usually they will not see a surgeon until they've seen their primary care physician, and the primary care physician will usually give them a trial of antacid therapy. And so there are different ways to treat the acid in the stomach. One is the standard Maalox, all the antacid stuff that you could buy over the counter, which directly neutralizes the acid. The next type of therapy that we had is what's called the histamine blockers, which can interfere with the secretion of acid in the stomach. And the most recent type of drugs that we now have available are called proton pump inhibitors, and they actually stop all acid production in the stomach. And so if you put these three medical therapies together, it actually represents a huge, huge expense of $10 billion a year in the U.S. And the drug companies have been very effective in getting these drugs available for over-the-counter use without a physician's intervention. And to me, that's very dangerous because patients will take these medications long-term and not understand that they can be damaging their esophagus. And that's why when you go see a physician, after you've had the trial of antacid therapy, if you respond, you should actually be taken off the antacid therapy after 6 to 8 weeks. And then if you have recurrent symptoms or persistent symptoms, then you really should be referred to a gastroenterologist for an endoscopy.
Oh, when they put a tube down.
So an endoscopy, they'll place a tube, have you swallow a tube that has a little lighted camera at the end, and they actually will inspect the lining of the esophagus and the stomach to look to see if there's been damage to the esophagus, inflammation, irritation in the esophagus called esophagitis, or whether the symptoms are from other things like ulcer disease in the stomach.
Now, after the diagnosis by the gastroenterologist, then they see you if they have esophagitis, or when do they see you?
Correct. If they have trouble swallowing, if they have esophagitis, or sometimes the endoscopist will find precancerous abnormalities referred to as Barrett's esophagus, where the damage to the lining of the esophagus has changed the character of the lining from what we call squamous cells to columnar cells, and this change is associated with an increased risk of cancer. And some patients, unfortunately, will also have esophageal cancer diagnosed.
And then when they see you, they are carrying with them these pictures from this examination, so you have an idea of what is going to go on.
Right. And
now you probably see a different type of patient also, where there are other procedures that you do which are less invasive if they don't have cancer.
correct. So when patients get to my office, I review this anatomy with them, and I explain to them that there are three components to the pathophysiology of reflux disease. So on this diagram, we have the esophagus again. The esophagus essentially functions as a pump. Then at the lower part of the esophagus, we have a valve called the lower esophageal sphincter. And then we have the stomach, which acts as the reservoir for the acid. When someone has reflux, the problem could be either with the pump, with the valve, or with the reservoir. If for some reason you have an abnormality in your esophagus and you cannot, and you don't have good kinetics going down the esophagus, the physiologic reflux that occurs all the time doesn't get cleared by the saliva. And so you could have symptoms because your esophagus doesn't work very well. If, on the other hand, the valve doesn't work either because the specialized muscle cells here have lost their tone, or because the anatomy of the valve has been altered, then the problem is the valve. And that's where surgical intervention is most effective. And in some patients, the problem is neither the esophagus or the valve, but rather that the stomach isn't working well. And if the stomach doesn't empty well, then obviously things are going to back up and you're going to get reflux up into the esophagus. So when they come to my office, they have usually had chronic symptoms. The best candidates for surgery are actually the ones who've responded to medical therapy. Sometimes if they haven't